Because of extremely rapid recent advances in systemic therapy, this is a relatively difficult topic to understand for surgical oncology residents. I have taken the help of a dear friend from medical oncology, Dr. Pragadish Tamarai Silvan. All possible stages of lung cancer, management of which can be summarized in this one slide, though it is an oversimplification. M1, systemic therapy. T4 or N3, chemoradiation. N2, previous video extensively discussed, chemoradiation. If all these boxes, all these criteria are met with, may be considered for neoadjuvant chemo-immuno followed by surgery. Once of those criteria being EGFR and ALK should be wild type. EORTC consensus of when to consider surgery in N2 disease. All this applies only to patients without EGFR or ALK targetable mutations in whom immunotherapy can be given. In patients with a targetable mutation, there is no question of neoadjuvant followed by reassessment in N2 disease. The clear option is definitive chemoradiation followed by surgery. Why is there this difference? I concluded my previous video with this slide. In patients without N2 disease, advanced resectable non N2 lung cancer, T3N1 with chest wall invasion, is there a difference in management between patients without and with targetable mutations? ESMO 2025 guidelines on resectable locally advanced lung cancer appears complicated. This flowchart can be summarized in a single line. Can we give immunotherapy before surgery for this patient? If the answer is yes, give chemo-immuno followed by reassessment for surgery. If the answer is no, operate upfront. In patients with targetable mutations, we cannot give immunotherapy, so upfront surgery. Without mutations, immunotherapy not feasible because of multiple reasons, operate upfront. So, yes, there is a difference in management between these two groups of patients. If immunotherapy is feasible, wild type, chemo-immuno, surgery, and immuno. If targetable mutations, upfront surgery followed by chemo, and then osimertinib for EGFR mutants and alectinib for ALK mutants. So, the three core questions of this video are why we cannot give immunotherapy in patients with targetable mutations. And if targeted therapy acts so well in this group of patients, why not give neoadjuvant targeted therapy? And the third question is why not just NACT in either of these two arms? Question 1. Immunotherapy cannot be given in patients with targetable mutations because by biology they are immunologically cold. The neoantigen load is very less. So immunotherapy acts very poorly. And if given by mistake to patients with targetable mutations, it leads to a very high risk of pneumonitis in the future when the TKIs are added. So leads to delay in TKI initiation. For these patients, the mainstay of treatment is TKI, targeted therapy, which acts very well. And if that is getting delayed by a drug, by a therapy which acts very poorly, that's why it's bad. So that is why patients with these targetable mutations were excluded in all the three peri-op chemoimmuno trials which we discussed in the previous video. The Keynote 671, AGN, and the Checkmate 77T. The second question, why can't we give neoadjuvant targeted? These two ongoing trials are yet to mature and are trying to answer this question, neoadara for osimertinib and alneo for alectinib. Until then, neoadjuvant targeted therapy can be considered only in the context of a trial. And also, unlike immunotherapy, which acts best in the presence of an intact tumor because of the high antigen load, neoantigen load, If TKIs are given in the presence of an intact tumor, there is a theoretical risk of premature resistance, the tumor cells developing resistance to the tyrosine kinase inhibition. The third question, why not just NACT? This is a very, very important slide. Unlike popular belief, contradictory to popular belief, NACT does not offer a survival advantage in lung cancer compared to adjuvant chemo alone. The main reason neoadjuvant therapy came up in a big way, the only survival benefit with neoadjuvant therapy was seen with the addition of immuno to chemo. Otherwise, in our example of this patient with a T3N1 disease, giving chemo followed by surgery or surgery followed by the same chemo, the survival is going to be the same. So, if chemo-immuno is not feasible for a patient with a resectable, by resectable, we are not discussing N2. The management of N2 we have discussed in great detail in the previous video. So, in summary, less than 4 centimeters without nodes, upfront surgery. So, this group of patients, which eventually they all require systemic therapy because their tumors are more than 4 centimeters or they are N1. So, somewhere down the line, they require systemic therapy. So, in this group of patients, when to consider NACT and when to operate upfront, if chemo-immuno is not feasible and if chemotherapy is the only option we have, we can consider NACT if it's a technically not straightforward resection. If a large area of chest wall is involved to reduce the extent of resection when the disease is close to major vessels but without frank invasion, or if the patient is not optimized for immediate surgery due to health or financial or logistic or several other reasons, so an anticipated delay, we can consider NACT. We should remember these three chemo-immuno-periop trials in both the arms which received neoadjuvant chemo-immuno and neoadjuvant chemo, roughly 17 to 20% of patients did not end up getting surgery after their neoadjuvant therapy because of various reasons, either disease progression or decline in general health status or adverse events because of the neoadjuvant therapy or a few other reasons. So, this has to be borne in mind while we consider NACT for a patient with a resectable locally advanced lung cancer. We are not going to achieve a survival benefit, and there is a roughly 20% chance that the patients may not come up on table. So, if it is technically challenging and if immediate surgery is not feasible, yes, NACT can be given. Otherwise, operating upfront is the better option.